Hello everyone, I am Dr. Sapkal here. The title for discussion today is the fetal skull. For this reason, we have to understand what is the status of the fetus in utero, and let us learn the different terminologies which are used in labor. The first terminology which is used is the lie. It is the relation of the fetal spine with the maternal spine, and that is how the lie can be a vertical lie where cephalic presentation may be there, or the breech presentation may be there where podalic bowl is in relation with the pelvic brim, like this. When it is transversely placed in relation with the pelvic brim, then it is a transverse lie, and when it is obliquely placed, it is oblique lie. Like this. The next one we have to understand is the what is the pole of the fetus which is occupying the pelvic brim, or it is in relation with the pelvic brim. Now, in these cases when it is a cephalic presentation, well flexed head, the vertex or the topmost portion of the head is in the lower uterine segment, and the outcome of the labor depends upon the fetal skull, because this is the fetal skull which negotiates the pelvis, and we have to decide whether pelvis is adequate for this size of the fetal head or not. And thus the fetal head is the best pelvimeter, and we have to understand everything about the fetus in these cases. The fetal skull as such has got two parts. The topmost part is the vault, and the part below the orbital ridges is the base of the skull. The base of the skull is bony. It protects the brainstem and the vasomotor center, while the vault of the fetal skull is the membranous bones, and they are compressible by a few millimeter in labor. This is how the vertex looks like. Now, vertex is the area which is bounded by different bones. Two bones are there on frontal side. One bone is occipital bone posteriorly, and laterally there are two parietal bones and two temporal bones on the vault. And among this there are sutures also. The sutures are the gaps in between the margins of the different bone. There are vertical suture and there is a transverse suture also. So, what are the vertical sutures on the fetal skull? The vertical sutures are the midline sutures. The midline sutures in between the two parietal bones. Posteriorly it ends with the posterior fontanelle, and anteriorly it ends with the anterior fontanelle. And the frontal suture is in between the two frontal bones. In the fetal skull there are two frontal bones, while in adult there is only one frontal bone. However, there are transverse sutures also. The one transverse suture which is in front is C shaped. This one is known as coronal suture. It is in between the parietals and the frontal bone. Lambdoid suture is posteriorly placed. It is L shaped. It is in between the two parietal and the occipital bone. So, these are the transverse sutures. These sutures, the fontanelle, they are the membranous gap between the margins of the bone. So, there is a gap, and these are known as fontanelles. This one is anterior fontanelle, this one is the posterior fontanelle. These fontanelles are made out only after PV examination and rupture of membranes. Rupture of membranes usually occurs in the second stage of the labor. Clinically significant are the two fontanelles on the fetal skull, the posterior fontanelle and the anterior fontanelle. Anterior fontanelle is also known as bregma, and the posterior fontanelle is known as lambda. There are temporal fontanelles on either side, and one more sagittal fontanelle is at the junction of the anterior 2/3 and 1/3 on the sagittal suture, but that is not clinically significant. Only two fontanelles are significant in labor. They are posterior fontanelle and anterior fontanelle. In vertex presentation, when the head is well flexed, the posterior fontanelle is felt on PV examination. When the head is deflexed, anterior fontanelle is felt on PV examination. So, what is the other terminology which is used in labor is the attitude of the fetus. It is the attitude is the relation of the fetal parts to each other, means the head is well flexed, the upper limbs are flexed and lower limbs are also well flexed. So, it is of universal flexion. Thus, in vertical line the head or the cephalic pole will be lower down. When the head is well flexed like this, we understand the occiput and the sinciput are the two poles. In vertex presentation, occiput is at a lower level when it is well flexed and sinciput is relatively at a higher level. So, here is the sinciput and here is the occiput. This is the sinciput pole and this is occiput. When the head is well flexed, occiput is at a lower level and sinciput is at a higher level. When occiput is at a lower level, naturally the nearby posterior fontanelle is felt on PV, and that is how we make out that it is a well flexed head on per vaginal examination. So, what is presentation? Presentation, normally the fetus is upside down, the cephalic pole is down and the podalic pole is at the top. So, what is presentation? It is that portion of the fetus which is in relation with the pelvic brim. So, this is vertex presentation. It is not cephalic, it is vertex. Vertex means well flexed head and the vertex is the area we have discussed. It area bounded by anterior fontanelle, posterior fontanelle and parietal eminences on either side. What is presenting part? The part felt on PV examination in a given presentation is presenting part. So, presentation is different. Presenting part is made out only after per vaginal examination, after rupture of membranes when patient is in labor. So, that is how we decide what is the presenting part in a given presentation. Hence, when it is a vertex presentation, vertex is the area we have described. We can make out the sagittal suture in midline and posterior fontanelle. So, what is the presenting part in vertex presentation? It is the sagittal suture and posterior fontanelle like this. So, we can make out this sagittal suture and posterior fontanelle, and by palpating posterior fontanelle we can make out what is the position of the fetus in uterus. What is denominator? It is a fixed point on the presenting part. Like in vertex presentation, the denominator is occiput. So, in relation to occiput, I describe 6 different positions in a given presentation. There are different diameters of the pelvis. This is the AP diameter, these two are the oblique diameters and one more is the transverse diameter. So, the relation of occiput to the pelvic brim we describe with the help of denominator. So, what is denominator in vertex presentation? It is occiput. That means, in relation to occiput, I describe different positions. Positions can be VLOA, VLOT, VLOP, VROP, vertex right occipital anterior, vertex right occipital transverse, like that. In face presentation, the denominator is mentum. In bro presentation, the denominator is bro. So, it will be anterior bro, posterior bro, like that. In breech presentation, when it is podalic pole is down, the sacrum is a denominator. So, in relation to sacrum, I describe the different positions. So, on the pelvic brim. So, the different positions are described. Positions means anterior position, posterior position, right position, left position, like that. So, different positions are described in relation to denominator. So, in any presentation you must remember what is the denominator and you can name the position, what is the position of the fetus in the uterus. That is how the area behind this is the pelvic brim, the posteriorly is the posterior position. When the denominator is in the transverse direction, it is transverse position. When the denominator is an anterior segment of the pelvis, it is a anterior position. Like that we describe different positions in a given presentation. Among vertex presentation, cephalic presentation, vertex is the commonest. It is 96.8%. So, it can be, this is vertex left occipito anterior, vertex right occipito anterior, like that, vertex right occipito transverse, or LOT, ROT. Instead of we may say it is a ROT, means vertex right occipito transverse, vertex left occipito transverse, like that. So, this is the spine in between and we have to direct it according to the direction of the diameters of the pelvic inlet. Okay. So, that is how different positions are described. When in a vertex presentation, we have to decide whether it is a normal or abnormal. Means normal position is anterior position or transverse position, when the occiput is anteriorly or transversely placed like this. It is anteriorly placed or transversely placed in relation with the pelvic brim. Whenever the occiput goes posteriorly, means the back of the fetus is in relation with the maternal spine, then it is an abnormal position, because in labor the occiput has to rotate through 3/8 of a circle for vaginal delivery to occur. So, prolonged labor results, that is why it is known as malposition or abnormal position. So, just remember, anterior position and transverse positions are normal, while where vaginal delivery, normal delivery can occur. However, occipito-posterior position, whether it is right or left, prolonged labor results, and hence it is described as abnormal position. So, posterior position is an abnormal position. Different type of labor and arrest of labor can occur. Now, in anterior position, when it is a well flexed head, the diameter of engagement will be different, and when it is deflexed head, the diameter of engagement will be different. In occipito-posterior position, the diameter of engagement is occipitofrontal, that we will learn later on. But what do you understand by diameter of engagement? This is the head, and this part is when it is well flexed, that is the circle of the head which enters the pelvic cavity. So, we are interested in knowing what is the diameter of this circle which enters the pelvic brim. Now, if the cephalic pole is down like this, with the degree of flexion or extension of the head, the transverse diameter of this circle will not change. However, the vertical diameter is going to change, like when the head is well flexed, it is vertex presentation. When the head is second, these two photographs are of deflexed head, where occipito-posterior position results. When head is completely extended, it is face presentation. When incomplete extension, it is brow presentation. I will repeat. So, these presentations will learn in different steps, different chapters. Okay. The first presentation we have to learn, that is the commonest, is the vertex. Then abnormal position means deflexed head. The diameter is little more, there prolonged labor results. Deflection may be less, deflection may be more. Next is complete extension, that is face presentation. Next is, last one is incomplete extension, that is brow presentation. Okay. So, like that different presentations we are going to learn in future. Vertex presentation is commonest, 96.8%. After that comes the breech, means the podalic bole is low down. Next one is the shoulder, face, and brow is the rarest one. Brow presentation is the rarest presentation seen in practice. Now, when the presenting part, when the position is abnormal, means occipito-posterior position, there is deflection of the head. If the head is deflexed, it can be, this is complete flexion of the head, this is deflection. So, deflection is more, like that. So, diameter of engagement will change on different positions when the deflection is less or more. In these cases, when the deflection, when it is well flexed head, I can make out the posterior fontanelle here. This is the posterior fontanelle on PV. When it is deflexed head, I can make out anterior fontanelle also, posterior fontanelle also. When deflection is more, only anterior fontanelle is made out on PV. That is how on PV examination in labor after rupture of membranes, we decide whether it is well flexed, little deflection, or deflection is more, because the more is the deflection, the more is the risk of arrest of labor. Okay. So, that is why it is very important to identify whether deflection is there or head is well flexed, and when the head is well flexed, it is the posterior fontanelle I can make out on PV. When head is deflexed, anterior fontanelle is made out on PV examination, very simple to understand. Now, what is face presentation? We have discussed when the head is completely well extended, it is face. When it is well flexed, it is vertex. When it is this is complete extension, this is partial extension, that is brow presentation, it is brow presentation. So, what do you understand by face? On the fetus skull, the part below the orbital ridges, these are the orbital ridges, the part below it is the face, and the part in face presentation on PV examination I can make out the orbital ridges, orbits or eyes, maxillary bones, oral cavity with the gum inside and the chin. So, this is a presenting part which is made out on per vaginal examination after rupture of membranes. So, it is face presentation, then you can diagnose we are dealing with the face presentation. Brow presentation along with the face, it includes the frontal bones also. So, there is a midline frontal suture here. So, that is how brow presentation includes the complete face plus forehead. That is why it is a difficult labor. Presenting part in the brow presentation is a anterior brow. If it is like this anteriorly, then it is known as anterior brow. If it is posteriorly like this, then it is posterior brow. So, which portion of the frontal parietal bone is down, frontal bone is down, decides whether it is anterior brow or posterior brow, whatever it may be, whether anterior or posterior, the labor is not going to occur in brow presentation. Different positions in face presentation. So, what is the denominator in face presentation? The denominator is mentum. Means what? In relation to the mentum, I describe 4 different positions or 6 rather, but important one are 4. So, I will say it is left mento anterior, right mento anterior, right mento posterior and left mento posterior like that. So, what is the denominator in face? Mentum. What is the denominator in brow? Anterior brow or posterior brow. Breech presentation. The podalic pole is down, simple to understand, podalic pole is down. Shoulder presentation when the axilla and the shoulder gets impacted, or I can make out on PV also and I can feel on palpation also. So, it can be shoulder presentation. Other rare one are cord presentation when I can make out the cord on PV. Compound presentation means along with the head I can make out the fingers of the hand. So, that is compound presentation. 2 presenting parts are made out simultaneously on PV examination, they are in relation with the lower retrine segment. Now, the presentation position can also be determined by per abdominal palpation of the head. Like abdominal palpation, there are Leopold's maneuver. There are different steps, first to 4th. So, the first step is, first Leopold maneuver is fundal palpation. We palpate the fundus and make out there is soft bulky portion is felt on either side. Then lateral palpation, I keep both 4 hands on either side and I can make out. So, this is how I palpate, do the lateral palpation with the 4 fingers of my hand. I can make out the spine on one side, I can make out the limbs on the other side. So, with the position of the spine I can determine the position of the occiput. So, I will decide if the spine is on right side, I will say it is vertex, right occipito anterior. If it is on left side, I will say vertex, left side, left occipito anterior. So, this will be vertex, right occipito anterior, this will be vertex, left occipito anterior, like that. When it goes posteriorly, vertex, right occipito posterior, vertex, left occipito posterior, like that. So, lateral palpation determines where is the back. It is very important, confirm the back with the by auscultating the fetal heart 5 centimeter away from the midline, I can make out here and confirm that the back is whether left side or right side. There are different Leopold's maneuver which are followed during abdominal palpation, where we can make out the presentation and position in a patient. Okay. So, here the first Leopold maneuver is fundal palpation, where I put my both hands, approximate the fingers at the top of the fundus of the uterus and palpate the fundal portion. So, soft bulky breech is felt on fundal palpation. Next one is I come down and palpate the lateral portion of the uterus. So, it is known as lateral palpation. I use my 4 fingers of my one hand and keep them. So, this is how the movements of the hand should be on the side of the back. I can make out the uniform back on the other one side, I can make out the limbs on the other side. So, this is what is lateral palpation. So, the side where I can make out the back is the occiput, the side where I can make out the limbs is the face area. So, the occiput denotes the what is the position. So, the back is on left side, so it is vertex left occipito-anterior. Suppose it goes transversely, then it is vertex left occipito-transverse. When it is goes posteriorly, then it is vertex left occipito-posterior. So, like that, by palpating the back, I can make out what is the position of the occiput in labor. Okay. So, that is how we determine the position of the back and occiput by lateral palpation. The third Leopold maneuver or the second pelvic grip is I stand on the right side of the patient, put my ulnar border of the right hand over the pubic symphysis and 4 fingers on one side, thumb on the other side, and I try to move the head. If the head is moving, it is floating. If it does not move, it is fixed. If it is not palpable at all, means it has it is engaged, it has entered the pelvic brim. Biparietal diameter has crossed the pelvic brim, head is not palpable per abdomen, sinciput is not palpable, and on per vaginal examination, the head is at the level of ischial spine. That is what is known as engagement. So, what do I understand by third pelvic Leopold's maneuver or pelvic examination? By second pelvic grip, I can make out whether the head is floating, whether the head is fixed or whether the head is engaged. That is how I can make out. The fourth maneuver also helps to understand whether it is a deflexed head or well flexed head. Suppose I do this way, I palpate on this side, on the side of the limbs I can make out the sinciput, on the side of the back I can make out the occiput. When the sinciput is at a higher level, it is well flexed head. When sinciput goes down and both sinciput and occiput are same level, it is a deflexed head. So, it is very simple. So, like that I go on this side, the side of the limbs is the sinciput, on the side of the back is the occiput, and determine the position of the sinciput and occiput. In well flexed head, occiput is at lower pole, and in deflexed head, both sinciput and occiput are at same level, or even in when it is extended, it is not felt at all. So, that is what is Leopold's maneuver. Second pelvic grip or the bony prominences means sinciput and occiput we make out. Digital examination also helps to confirm the presentation position. Usually it can be made out only after rupture of membrane, means when patient is in the second stage of labor after full dilatation of cervix and rupture of membranes. What I can make out? I can make out the presenting part. Thus, in vertex presentation, what can be the presenting part? The presenting part can be fontanelle, can be sagittal suture, and the direction of the fontanelle will indicate the direction of the position, whether it is left side, right side, whether it is anterior, whether it is posterior, I can make out. So, by palpating posterior fontanelle, I can identify the position. But how to know I am palpating this posterior fontanelle only? Suppose by a digital examination, I palpate the sagittal suture, I go on this side, I go on this side, and I locate that there are 3 radiating sutures, and that is why it is a posterior fontanelle. Suppose on PV examination, I feel the sagittal suture and I feel the anterior fontanelle. It is a large fontanelle, 3 centimeter wide, diamond shaped. There are 4 radiating sutures. Its direction will indicate what? Sinciput. It is felt in deflexed head. Well flexed head, what I will feel? Posterior fontanelle. Deflexed head, what I can make out? Anterior fontanelle. So, it is a malposition. So, what is the significance of this anterior fontanelle after birth? There is intramembranous ossification at the 18 months of child. If it does not get ossified by 2 years of age, it is pathological. Thus, we must understand when the head is deflexed, anterior fontanelle is felt, when the head is well flexed, posterior fontanelle is felt, but we have to identify whether it is anterior or posterior by sutures radiating around it. Then let us learn the diameters. These diameters are little difficult to understand. but let us make them little easier, and whatever diameters are important from clinical point of view we will learn in detail, and practical examination point of view also they are important. For practical examination they ask you what is the diameter of engagement in vertex, what is the diameter of engagement in face presentation, like that. So, let us learn the diameter of engagement. To understand different diameters of engagement, we have to learn some bony parts on the fetal skull. What are they? Bregma. Bregma is the anterior-frontal or the highest point on the vertex. This surface is plane, so highest point of vertex is bregma. Okay? So, you remember what is bregma? Highest point of the vertex. Occiput, very easy to understand, occipital bone. Then subocciput. Subocciput, this is the margin of the foramen magnum and this is the occiput. So, midpoint of the two is subocciput. Then submentum, this is the chin and this is the angle of the mandible. So, midpoint of the chin and the angle of mandible or anterior surface of the neck comes the submentum. So, what are the points we have learned? Submentum, midpoint of the chin and angle of mandible, subocciput, midpoint of the occiput and the foramen magnum, posterior margin, and bregma. Okay. Frontal point is the frontal bone, but frontal point is different for different diameters. So, just understand bregma is the highest point of vertex, submentum and subocciput. Okay. What is the diameter of the engagement? What do you understand? When this circle of the head enters the pelvic brim, the transverse diameter also, this circle has got transverse diameter also, it has got vertical diameter also. So, when the head is well flexed or deflexed, this transverse diameter will not change. So, in the examination, practical examination, if they ask you what is the diameter of engagement in vertex presentation, you should say about the vertical diameter, not the biparietal diameter or transverse diameter. This transverse biparietal diameter is 9.5 centimeter. It is the distance between the two parietal eminences. So, it is 9.5 centimeter. Other transverse diameters, they are not clinically significant. However, we must know them from MCQ point of view. So, what is the bitemporal diameter? Bitemporal diameter is 8.5, here by mistake I written biparietal, 8.5 centimeter. Super subparietal is 8.5 centimeter, bitemporal is 8 centimeter and bimustard is 7.5 centimeters. So, these are the transverse diameters of this circle, these are the transverse diameters. Midline diameters, they are different, let us learn them step by step. There are two diameter of engagements. When the head is well flexed, it is vertex, when it is well extended, it is face presentation. Clear? Now, let us learn what is the diameter of engagement in vertex presentation. When it is well flexed head, it is suboccipitobregmatic, this diameter. When it is well extended head, submentobregmatic on either side. So, this is how it is. So, when it is well flexed head, what is the diameter of engagement? Suboccipitobregmatic. When it is well extended head, what is the diameter of engagement? Submentobregmatic. Very simple to understand. So, remember suboccipitobregmatic, submentobregmatic, biparietal diameter, they are equal, they are 9.5 centimeter. None of the diameters of the pelvis are less than 10. So, this least pelvic dimension is 10. This one is 11, this is 12, this is 13. So, the head can enter through all diameters. It can enter this way when it is vertex. So, biparietal diameter and the AP diameter of engagement both are 9.5 centimeter. So, today by now you understand there are three diameters. One is suboccipitobregmatic, second is submentobregmatic and third one is biparietal. These three diameters of the fetus they are equal, they are 9.5 centimeter. Okay. So, by now you know three diameters, well done. Now, what is suboccipitobregmatic? We have learned. Submentobregmatic we have learned. Now, diameter of engagement in broad presentation when it is incomplete. This is complete extension, this is incomplete extension, means there is a role of frontal bone now. So, what is the diameter? Verticomental or mentovertical, the reverse way also you can see. See, it is 13.25 centimeters. It is the largest diameter of the fetal skull. You must know it and remember it from MCQ point of view. Okay? So, and whenever it is a broad presentation and what is the diameter? 13 point, what is the measurement? 13.25. Naturally, the head cannot enter through AP also, oblique also, transverse also, none of the diameters are more than 13. This one is 11, this one is 12, this one is 13. 13.25, it is too big. Vaginal delivery is not possible in bro. The treatment is always elective cesarean section. That means I have to take the patient before onset of the labor for cesarean section. Otherwise, there is a risk of rupture uterus, cord prolapse and what not. So, remember bro presentation is a very abnormal condition where the largest diameter of the fetal skull is the problem, and that is why cesarean section is required. Abnormal position and normal position. These two terminologies you must understand. It is a position. I have not said it is a presentation. What is abnormal position? Is occipito-posterior position. What happens? What goes wrong there? The head is deflexed. Okay. There are two diameters of engagement in occipito-posterior position. There are two diameters of engagement. Remember, when the head is deflexed, there are two diameters. One is occipito-frontal, the other is suboccipito-frontal. Frontal point for two different diameters are different. They are not same. When the deflection is less, suboccipito-frontal diameter is the diameter of engagement. When deflection is more, occipito-frontal diameter is the diameter of engagement. O for O means what? How do you remember it? Occipito-posterior position, occipito-frontal diameter is the diameter of engagement. The measurement of this occipito-frontal diameter is more, suboccipit means less. What is suboccipit? We know the midpoint of the foramen magnum and occipital protuberance is suboccipit. So, suboccipito-frontal, the frontal point is 2.5 centimeter in front of the anterior fontanelle, and for occipito-frontal, the frontal point is nasion. So, remember occipito-frontal is occiput and nasion, small word, occiput, nasion, occipito-frontal. Subocciput, midpoint is a long word, and frontal also 2.5 centimeter from the center of the anterior margin of the anterior fontanelle or center of the anterior fontanelle is frontal point. So, there are two diameters of it. You see here, this is the occipito-frontal from occiput to nasion, and here it is a next slide is a suboccipito-frontal. Subocciput is below. When occipital protuberance comes into picture, then it is a big one. So, the suboccipito-frontal is 10 centimeter and occipito-frontal is 11.25 centimeter. This one is suboccipito-frontal. So, remember the names of the diameter. Okay. This slide is very good to remember the names. In vertex presentation, what is the diameter of engagement? Suboccipito-bregmatic. In deflexed head, what is the engagement diameter? Suboccipito-frontal. When deflection is more, what is the diameter of engagement? Occipito-frontal. So, here frontal point is there. Here what is the point? Bregma. So, in vertex presentation, suboccipito-bregmatic. In deflexed head, suboccipito-frontal. Deflection is more, occipito-frontal. That is how two more diameters you remember in vertex presentation. Sagittal suture is the presenting part in vertex. Usually a short question answer is asked on this sagittal suture. So, let us learn in detail. Okay. What is sagittal suture? It is a midline suture. It can be made out on PV examination in vertex presentation when the head is well flexed. It ends posteriorly with the posterior fontanelle, we have learned, and anteriorly with the anterior fontanelle. In vertex presentation, when the posterior fontanelle is felt on PV examination, we can identify it by 3 radiating sutures from it. And this sagittal suture along with the denominator, that is occiput, will indicate the direction of the occiput, whether it is posteriorly placed, whether it is anteriorly placed, how it is, I can make out. So, in this photograph, in this slide, we had decided that I had drawn the blue arrow with the as O. So, this circle indicates the direction of the occiput. So, this is anterior position. The second one is the transverse direction it is. So, it is VLOT, and the last one is the VLOP, the occiput goes posteriorly. So, that is how the sagittal suture along with the posterior fontanelle on PV examination, I can make out what is the position of the fetus in uterus. So, that is the significance of sagittal suture in obstetrics. If it is transversely placed, when the head enters in the transverse diameter of the pelvis, then it rotates towards the midline in second stage of labor when it is on pelvic floor, and this rotation should be identified by PV examination. That is known as internal rotation. The degree of internal rotation is very, very important in labor because it depends upon the decision making of forceps application. In these cases, when the head is at +2 station and there is the sagittal suture is on oblique direction, means less than 45 degree of rotation is there. That is the first line I have shown there. There when I apply the forceps, it is known as low forceps application, and the second one is when the head station is little below, means below to +2 station, and there is complete rotation, means sagittal suture is in the midline, I can apply forceps on either side, blades of the forceps on either side. That application is known as prophylactic forceps application. So, in the examination if you are asked, you must remember low forceps delivery means head is short of 45 degree, less than 45 degree of rotation, and head station is +2 station, and complete internal rotation with head below +2 station is prophylactic forceps application. So, these two terminologies are asked in the examination, you must remember them. Okay. There are certain pathological conditions also I can identify in relation with the sagittal suture, like if there is a big caput over the sagittal suture, I cannot make out the sagittal suture at all, then it is a ominous sign, it is a bad sign, it is a sign of prolonged labor, it is a sign of obstructed labor also. There immediate cesarean section is required or opinion of a senior consultant is required in these cases. There is widening of suture in cases of hydrocephalus. On X-ray, suppose nowadays we do not do the X-ray, we follow the other investigations like sonography, but on intrauterine death, the one sign is known as Spalding sign, where there is overlapping of the skull bones over each other, that is a Spalding sign on X-ray. When I apply the vacuum, or it is a type of instrumental delivery where a cup of the vacuum is applied at the posterior fontanelle and traction is given to the head in second stage of labor. So, in these cases it is known as vacuum application. There are certain criteria for vacuum application, how to apply cup, where to apply the cup. I can suppose this is the full dilatation of cervix and I can make out the sagittal suture and posterior fontanelle. Suppose I am applying the cup here, where the cup should go, normally it should go over the posterior fontanelle. This is the sagittal suture which is in the midline. The cup should not go on either side. The cup should not go on the anterior fontanelle. If the cup goes here, I give the traction, there is deflection of the head. So, what should be there? This point is known as flexion point. My cup should go, the cup of the vacuum should go over the posterior fontanelle itself. If it goes eccentrically, then there is failure of vacuum, failure of the instrumental delivery. So, that is one principle which I should know while I apply vacuum in relation with the sagittal suture and posterior fontanelle. On the flexion point, we apply the caput. The margin of the cup should be 3 centimeter away. Here is the cup, then it should be 3 centimeter away from the anterior fontanelle. So, this is how the position of the cup should be there normally, that is flexion point. That point is known as flexion point. One more terminology which is used in obstetric is asynclitism of the head. In grand multipara, because of repeated childbirth, there is a loss of calcium and the inlet of the pelvis becomes flat. So, there is flattening of the pelvis and AP diameter of the inlet is less. So, we have learned the transverse diameter of the engagement is biparietal diameter. It enters the pelvic brim, head enters in one of the transverse diameter or oblique diameter like this. So, when it enters into the pelvic cavity, if the inlet is contracted, then the BPD cannot cross the inlet. In these cases, there is lateral tilt of the head and super subparietal diameter enters the pelvic brim. This lateral tilt of the head is known as asynclitism. The terminology used is asynclitism of the head. Naturally, when the sagittal suture is on the midline, like this, it is normal. But if there is lateral tilt, what will happen? The sagittal suture will go posteriorly and it will become anterior parietal presentation. If it is tilted like this, the parietal bone, this posterior parietal bone will be seen and the sagittal suture will go anteriorly. So, like this, there is lateral tilt of the head, that is known as asynclitism. It is seen in the flat pelvis. Biparietal diameter is 9.5 centimeter, super subparietal diameter is 8.5 centimeter. So, there is reduction in the diameter by 1 centimeter. Thus, vaginal delivery is possible if anterior parietal presentation is there. Means what? There is the head enters like this, anterior parietal bone is lower down. Posterior parietal bone is lower down, this is posterior parietal, this is anterior parietal. So, there is lateral tilt of the head. Normally, sagittal suture is in the midline. So, what happens? Super subparietal diameter is the diameter of engagement. When it is anterior parietal presentation, patient can deliver vaginally normally. However, posterior parietal presentation, PPP, 3 P's are there. Poor prognosis, you remember like this, posterior parietal presentation, poor prognosis. What is the treatment in these cases? Prognosis is poor, naturally the patient lands up into cesarean section. Okay. What is molding? Molding is also one of the term which is used in obstetrics. Often it is seen with the obstructed labor, when the pelvis is contracted or the fetus is of large size. There the compression of these bones of the vault little by 1 or 2 millimeter is possible. It is normal, it is physiological. But with this overlapping of the parietal bones to each other and two frontal bones go below parietals and occipital bone goes below the parietal. So, there is definite relation in between. So, what happens in the molding? There is overlapping of parietal, frontal bones go below parietal, occipital bone goes below parietal and there is a overlapping. More than 3 or 4 millimeter overlapping will cause what? Intracranial hemorrhage. The compression is too much. That is why it is a bad sign, ominous sign. Where do you find the molding? I can detect molding on per vaginal examination in second stage of labor. In cases of prolonged labor, obstructed labor, the molding may be there. It is a sign of fetal distress also. There are different degrees of molding. Like a first degree, the gap between the bones is lost, like this. Normally, there is a sagittal suture, there is a membranous gap between the two parietals. But what happens here? In the molding, first degree molding, the gap is lost. Second degree molding, there is overlapping of the bone, but the bones can be separated digitally. When I do PV examination, I can little separation of the bones is possible, it is okay, but bones are separable. In third degree, the head is so jammed in the pelvic cavity that the bones cannot be separated, they are fixed, that is bad sign. Okay. The next, if still no intervention is done, then even the tear in the dura mater can occur and intracranial hemorrhage can occur. In these cases, naturally increasing molding is an ominous sign. It is an indication of prolonged labor. It is an indication of fetal distress also. The next condition which is identified after birth is cephalhematoma. It is a hemorrhage below the periosteum. The bones are membranous, there is a periosteum. Below the periosteum, there is a hemorrhage. Whenever there is a hemorrhage, naturally we understand there is a trauma. So, where the trauma can occur? Prominent points, parietal bone on this side, parietal bones in labor, these two can get injured. Naturally, hematoma results there. The name of the hematoma is cephalhematoma. Hematoma will take some time to be seen at birth. So, it is seen 24 hours after birth because it is below the bone. It is not seen at birth, neither it is seen during labor. So, the cephalohematoma is seen 24 hours after delivery and it disappears by 6 weeks. Whenever you see, whenever there is a fracture elsewhere, the orthopedician what they do? They keep the plaster for 6 weeks. So, remember whenever there is hemorrhage, whenever there is trauma, the hematoma takes at least 6 weeks to get absorbed. So, after 6 weeks it will dissolve. So, it disappears by 6 weeks. It is a concealed sealed hemorrhage, so no treatment is required. It disappears spontaneously. What is the etiology? Suppose I apply the blade on this side, forceps, blade this side or this side, there is a trauma to the parietal bone. So, after forceps delivery there is a chance of cephalohematoma. The site of the cephalohematoma, prominence of the parietal bone, it is confined to the specific bone because it is subperiosteal, it is a pathology of that bone. So, it is confined to the bone, it will not cross the sagittal suture, it will not cross and the little pitting may be there and it is seen after birth. On day 2 when you visit the postnatal ward, you observe the baby, there the mother will complain of a swelling and that is not a caput, that is a cephalohematoma. What is the treatment? No treatment is required. However, if it is a big hematoma here, by the time the newborn can have jaundice, the newborn can have associated fractures also, skull bones. One more condition you have to differentiate in this newborn is the meningocele. It is a herniation of membranes, meninges. There, trans-elimination test will be negative in cephalohematoma, in meningocele will be positive and coughing impulse will also be there in meningocele and in cephalohematoma it is not seen. Okay. So, you have to differentiate it from meningocele, very rare condition and the site is also not common. Next condition which is comparable with the cephalohematoma is the caput. Usually in theory or practical the question is asked on this topic. Okay. What is caput? It is a serosanguinous exudate. Exudate, it is a swelling exudate where it will collect below the scalp. It is not concerned with the bones at all. So, it is on the presenting part. It is seen because of compression of the bones of the fetus in labor, in second stage of the labor. If the station of the head is stagnated there for a long time, then venous return does not occur, lymphatic drainage will not occur and there will be a big swelling over the fetal head. That caput I can identify in labor on PV examination. Once the compression is relieved after birth, the caput will disappear. Slowly the venous circulation will improve, the lymphatic drainage will improve and the caput will disappear. That is how I can make it out on PV examination. Sagittal suture cannot be made out, fontanelle cannot be identified, there is a big caput, big swelling, the station of the head cannot be determined. It is a sign of fetal distress, it is a sign of prolonged labor. Forceps are contraindicated, vacuum is not applied, caput is a bad sign, it is a sign of fetal distress also. So, early decision making of caesarean section is very important. After birth, if I had to decide whether it is caput, where it is located, it covers the sagittal suture also, the caput, because it is a swelling over the subcutaneous tissue. No drainage is required, nothing is done. In cases of vacuum application, there is a metal cup or a plastic cup which is applied over the head, okay, over the flexion point. So, what will happen? What happens here is when we create a vacuum with the suction effect, there is a swelling, there is a exudate formation in the scalp and that artificially created caput, what is the name of that condition is chignon, C-H-I-G-N-O-N. Presence of chignon is seen after birth in vacuum application, okay. That is an artificially created, it is a not sign of fetal distress or prolonged labor. By identifying the position of the caput, I can identify what was the position of the intrauterine position of the fetus. Just remember in LOA anterior position, the caput will be on opposite bone. So, VLOA right parietal bone, VROA left parietal bone. Okay. In posterior position at the as there is approximation of maternal and fetal spine, right and left will be same. So, VROP in right parietal bone, LOP in left parietal bone. In face presentation, the caput will be over the swelling over the orbits and the mouth. In brow presentation, the swelling over the forehead and the oral cavity. That is how we can identify the caput and decide what was the position. In bridge presentation, the caput can be over the genitalia. In shoulder presentation, the caput will be over the prolapsed hand, axilla, shoulder, like that, and in prolapsed cord, the cord will be swollen. So, that is what is caput, you understand? This is just a swelling, it disappears afterwards. That is how we end here with all aspects of the fetal skull. Thank you so much for the patient hearing. Thanks a lot.